So what you need to know, this is, I will send this, it's only Golian part, okay? Golian is very good book for GI pathology, okay, after Robbins, because there is some information that is not in pathoma, for example, okay? So I will send this one. Here is highlighted all important information, and you can start from it. But lecture I will give you from this part. As for in syllabus, we have oral pathology and then esophagus and stomach and like this. From oral pathology, I want to discuss this cleft palate as a part of this oral pathology. We discussed in respiratory system, maybe you remember, right? These vocal cords and nasopharyngeal carcinoma and stuff. And here we talk about oral cavity. What you need to know, in oral cavity we have such pathologies. Oral cavity is lined with squamous epithelium. You remember this? And for that reason, you are expecting pathologies that are appropriate to squamous cell, right? For example, you can find, for example, inflammatory conditions. You can find human papillomavirus infection that is really high yield, and some congenital anomalies as well, and finally carcinoma. As congenital anomalies are this, whatever you see, cleft palate and lip, that is actually important, very common, very, very common. And it is usually, you see failure, facial prominence to fuse. And that's why you have this split palate, okay? And these anomalies usually happen in early pregnancy usually. Around the mouth, you find also some inflammatory condition that is aphthous ulcer, that is painful sore, okay, painful ulceration, but pay attention that it is not erosion, but it is superficial ulceration, okay? There is difference between erosion and ulceration, so it is not erosion. Erosion is limited only epithelial layer, okay? Here you have ulceration, but just superficial ulceration. And you should find under microscope, this ulcer, like in all ulcerations, you should find granulation tissue, and this granulation tissue is surrounded by erythema, okay? So there is blood vessels. That is aphthous ulcer. Usually it's painful, very, very common. And aphthous ulcer usually is solitary. One aphthous ulcer. It is related to stress and resolve spontaneously. But there is one condition where aphthous ulcer you have in along with other conditions as well. You should have, for example, recurrent aphthous ulcer, genital ulcers, and uveitis, okay, visual disturbances. If you have this triad, okay, recurrent aphthous ulcer, then it is Behçet syndrome, and usually it is related to vasculitis. Okay, we have such autoimmune condition, vasculitis, of small vessel vasculitis, that cause this Behçet syndrome. Okay, so usually we don't know what is etiology, but it most likely is related to viral infection. Okay, Behçet syndrome is actually a complication of viral infection. Oral herpes, all of you know, okay, what is oral herpes? It is related to HPV-1 virus, but you should know what is HPV-2. HPV-2 actually causes genital herpes, okay, and you should not make mistake there. Oral herpes virus 1 and herpes virus 2. Pathogenesis of herpes virus is very interesting and important, and you can read it. Actually, detailed pathogenesis is explained in Robbins if you want them. And in Golian, you have short information about it, but you need to know what is important about this herpes virus. This infection actually occurs in the early childhood. Patients get infected in early childhood. but it does not manifest clinically, okay? Just virus remains dormant in the terminal, the trigeminal ganglia, and what happens is during stress and direct sunlight, for example, this virus get activated, and it gives this ulcer. What type of ulcers you have? There's multiple vesicles you will find, and if this vesicle burst out, it gives hyperemia, okay, and painful ulcer. So pathogenesis, again, how this herpes virus caused ulcer, that is important. And high-yield information here is that virus remains in the ganglia, okay, and only after stress it activates and causes this damage of epithelial cell. Interesting part is actually carcinoma of the oral mucosa. And what do you need to know? Here is mentioned that alcohol and tobacco is risk factor, but human papillomavirus also is risk factor, can cause this carcinoma. And why actually? You know, the human papillomavirus infects squamous epithelial cells only, and we have low risk and high risk human papillomavirus. And how is HPV important? We know we studied in cervical carcinoma. It causes cervical carcinoma, okay? Cervix, also vaginal carcinoma. It causes also vulval carcinoma, and it also can cause this oral carcinoma, right? And mechanism is important. Sequence. HPV not directly cause cancer. In the beginning, it caused dysplasia. Okay, in the beginning, at first, it caused dysplasia and then carcinoma. How on physical examination, how it manifests, okay, either it is dysplasia or carcinoma. You should see leukoplakia. Okay, leukoplakia is white patch on the epithelium, okay, and that is sign of dysplasia. But there are other chances. We have other conditions which manifest with leukoplakia, and the same happens actually on vulva. And we need to make differential diagnosis. Wherever you find leukoplakia on this epithelial, squamous epithelium, like in mouth or vulva or vagina, you should make differential diagnosis. Is it dysplasia? Is it lichen, for example, and this specific type of dermatosis, or is it cancer? Similar to vulva dysplasia, VIN is there. You should find, guys, if it is dysplasia, you should find coilocytes, okay? Coilocytes. Coilocytes is actually HPV infected cell. But how do you know if it is dysplasia, or how do you know it is candida, or what else? Hairy leukoplakia. Just a moment. Guys, we need to scrape away the tongue, okay? If you find the white plaque on the tongue, you need to scrape it away, and if it easily removes this white plaque, for example, that means it is candida, okay? If it easily removes. But we have another case as well. For example, the white plaque you find on the lateral side of the tongue. What you see here, literally like this. This is hairy leukoplakia, okay? You need to differentiate hairy leukoplakia from candida or this dysplasia, right? Location here helps. Location. On the right side, on the lateral side of the tongue, if you find these plaques, that most likely will be hairy leukoplakia, and you can easily scrape it away. And cause is different, okay? If dysplasia is caused by HPV, this hairy leukoplakia is caused by EBV, all right, EBV. And usually not precancerous, you see, not precancerous. Why is it important? Hairy leukoplakia is not precancerous, but if you find dysplasia, all right, which this white plaque usually in dysplasia cannot be removed, okay, we cannot scrape it away. That means it is dysplasia, and the dysplasia is a precancerous condition. It will lead to squamous cell carcinoma. But in here is the leukoplakia location. Again, it is on the lateral side. It is not precancerous condition. And leukoplakia, and it scrape away easily. All right, but this is white plague. But you can leukoplakia is white patches, but you can find red patches. Same thing we have in vulva. Vulva, these are the lesions. Erythroplakia means actually you find red patches, okay, red patches, and it is sign of hyperplasia usually, hyperplastic epithelium you find. And here it mentioned that erythroplakia, if you find red plaque, that means highly vascularized squamous dysplasia. And what it means, highly vascularized squamous dysplasia? Dysplasia, anyway, is sign of the lack of differentiation. Okay, you lose differentiation, and the cells might undergo malignant transformation. But even if it is highly vascularized, that is definitely sign of cancer. It's not sign of cancer, but it is precancerous condition from this area. Definitely will arise cancer. Okay, so what lesions you see here, erythroplakia, that is how we see it on vulva epithelium. And in the vulva epithelium, actually, we have other type of hyperplastic disorder which give leather skin appearance. Okay, type of lichens. Okay, lichens we don't have in mouth, but in appearance, how it looks like this lesion. Okay, so precancerous condition. That type of question you have usually it's a frequently asked question on board exams and in test. Maybe I will put as well. Precursor lesions, you should know. Precursor lesions are lesions that can lead to cancer. And two options you have, leukoplakia and erythroplakia. If the question is what has the higher risk of developing cancer, answer will be erythroplakia. Because you have this plastic squamous cell with highly vascular, with high vascularization. Okay, there is very high risk of cancer. But in leukoplakia, you might find the dysplasia, but in case of leukoplakia, you need to make differential diagnosis from candida and hairy leukoplakia. Okay, in none of them, candida and hairy leukoplakia are not precancerous, and the location is different. Okay, candida on the cover the whole tongue, but hairy leukoplakia are only on lateral side of tongue. Salivary gland is important, guys, particularly tumors, and please read in Golian or in Robbins, wherever you want, who attend me here. You can read Robbins. These three tumors are, we don't have many tumors actually in the salivary gland, but these two are most common, and you need to make differential diagnosis between them. Also, pay attention to infectious inflammatory conditions of salivary gland, like mumps is most common virus that affect this parotid gland, and cellulitis is inflammatory condition that can be caused by infection itself, for example, staph aureus, okay, or you might have because you might have obstruction, okay, and you know from general pathology that if you have a blocked obstruction of the duct, it will lead to inflammation of the gland. Okay, and you know, same thing, for example, Bartholin gland we have in vagina, right? That means glands when get inflamed by infectious agent, that means bacterial agent, for example, it usually is unilateral. It is not bilateral, and it is painful. Okay, it's cause infection. As for mumps is interesting because it gives many questions about differential diagnosis and what the differential diagnosis you need to make. For example, in case of mumps virus, it infects parotid glands. Okay, it can cause infection of testicles, infection of testicles, and cause orchitis, and it can cause pancreatitis and aseptic meningitis. And now, how we make differential diagnosis? For example, the laboratory test that we measure in this case in case of salivary gland inflammation, okay, bilateral. You see if bacterial infection causes inflammation, salidinitis, and the different glands are infected actually. No salivary glands. In fact, it is unilateral, but mumps cause bilateral. That is also important clinical information. Bilateral inflammation of parotid gland, and you will find, guys, increased amylase, okay, increased amylase. But it happens as well in pancreatitis as well. Pancreatitis manifests as, during acute pancreatitis. You will find increased amylase in serum, and you need to differentiate actually what happens. If patient has mumps virus and increased amylase, most likely will be parotid gland infection, okay, inflammation. And also there is a P and E amylase, different types of amylase, as I remember, different types of amylase they release, okay, and this, according to this type of amylase, we can make differential diagnosis. Either this amylase increase due to parotid salivary glands or pancreas. All right. Also pay attention that mumps, if you get mumps infection before the age of 10, it does not cause orchitis, but after the age of 10, it can lead to orchitis, and complication is sterility. Okay, sterility is a major complication. So when mumps virus have a teenager get infected with mumps virus, that is particularly dangerous condition because it leads to orchitis. Cancers again, here you just need to memorize, guys, because of different type of tumors, pleomorphic adenoma, Warthin tumor, mucoepidermal carcinoma. All of them you find in parotid glands. Usually tumors, the parotid gland is the biggest tumor, and all these tumors you find there. How we make differential diagnosis, pay attention in clinical case should be mentioned. Morphological changes, okay, microphotograph changes, and you should memorize what happens. Stromal cartilage and epithelial cells you should not find in, and so stromal cartilage and epithelial cells, and biphasic tumor means in one high power field, for example, or low power field, you should find two different tissues. And pleomorphic, that is why there is pleomorphism, you know, that is different size and shape cells if you find, right? So adenoma is benign tumor, it is adenoma is benign tumor, but it is pleomorphic, that means different types of tissue you will find. And biphasic pleomorphic adenoma, just memorize that it is biphasic, and biphasic means you should different tissue you should find there. Okay, it is benign usually. It never becomes carcinoma in pathology, which he mentioned rarely, but pleomorphic adenoma is quite common, and usually it does not undergo malignant transformation, but it grows quite big. Okay, it grows quite big, so for that reason you need to do surgery in this case. But high recurrence, that is important, high recurrence. You can make this, and it is not an easy operation, actually. It's difficult to make this operation, but there is very high risk of recurrence. For that reason, usually it does not help. Okay, so that's why pleomorphic adenoma is a bad condition, actually. Unlike Warthin tumor, this is a cystic tumor with germinal center and lots of lymphocytes. That is also easy to make the diagnosis because Warthin tumor is second most common tumor, second most common. Benign is most common everywhere. In the salivary gland tumors, benign tumors are more common, malignant are really rare. But second most common and the third most common. This is epidemiological data, and you need to memorize. It does not change. This information is in pathoma, and you will find it in Robbins and in all big books as well. So Warthin tumor is a lymphocytic tumor. Okay, the germinal center, it grows like germinal forming germinal centers, and you will find a lot of lymphocytes. So how would be describe this Warthin tumor? It will be described like uniform cells, high cellularity, and cells will be like uniform appearance you will find, okay? And this uniform appearance actually means that they are most likely lymphocytes, okay? And the lymphocyte, the lymphocytic tumor actually, it is not like a lymphocytic tumor, but you will find the germinal centers of lymphocytes, lymphocyte infiltrate, and that is very typical to Warthin tumor. Mucoepidermoid carcinoma is mucinous, and squamous carcinoma. It is quite aggressive actually, okay? It is quite aggressive because it has abnormal growth pattern. Abnormal growth pattern because of involvement of cranial nerve 7. All right. It does not metastasize, guys. It does not metastasize, but the pattern of growth is very bad. And the location of the tumors actually is quite bad, and it makes surgery quite difficult, as well as they are prone to recur. Now, next the condition, guys, you will find something in the Gaussian as well, and you will read it as well. In esophagus, what groups of disorders you are expecting? In whole GI, please memorize like this. In Robbins, you have this classification. Like congenital anomalies, you should know. Infectious pathologies we have, inflammatory conditions we have there, like acute and chronic inflammation, vascular disorders, definitely vascular disorders, you know, like atherosclerosis, thrombosis, emboli, the congenital vascular pathologies you will find in GI tract. Inflammatory condition, non-specific inflammatory conditions, for example, inflammatory bowel disease, you should find, and carcinomas and polyps. Okay, that type of disorders we find in GI, but congenital anomalies are inevitable in all parts, like in esophagus, in stomach, small and large intestine. You will find these congenital anomalies. Now we start the most common, actually, the most common different types of tracheoesophageal fistula we have, but that is most common type, tracheoesophageal, where you find both, okay? Most common variant of proximal esophageal atresia. Proximal is important, okay? Proximal because it is in upper part, okay? Proximal esophageal atresia, and you find fistula, like trachea and esophagus are fused together, and you find fistula between them. For that reason, actually, in this atresia you can find in esophagus, you can find also not atresia but stenosis in the stomach, like pyloric stenosis, I will mention it, and duodenal atresia you can find as well. And wherever you have this stenosis or atresia, guys, mother will have polyhydramnios, okay? Polyhydramnios is really high yield symptom in GI tract pathology. Wherever you find, you know already oligohydramnios, right? Oligohydramnios. And oligohydramnios means, for example, you find in renogenesis, right? Or and it can lead to pulmonary hyperplasia and all this stuff you know already. But in GI pathology, in GI congenital anomalies, you need to expect polyhydramnios. And why? Because they cannot swallow, okay, this amniotic fluid, and it accumulates in uterus, right? And the amniotic fluid accumulates there. And when now this baby is born, what happened? They have vomiting, okay? Immediately they eat. After breastfeeding, for example, they vomit, okay? That is one thing, very important. And why it is important, guys? Presentation, pay attention to presentation. Vomiting can happen immediately after eating, after 2 weeks, for example, after 2 weeks, and vomiting can be projectile as well. That are all clinical signs. In this case, tracheoesophageal fistula, you have immediate vomiting. polyhydramnios, mother will have polyhydramnios. Why aspiration? Aspiration occurs because of fistula, right? You have fistula here, and abdominal distension. Abdominal distension is because of this aspiration. Esophageal web is not common, by the way. It is not common, but if you find something like this, a protrusion from mucosal layer, this is protrusion from the mucosal layer, that is dangerous condition. Okay, it does not cause any severe clinical manifestation, but it's precancerous, guys, because it is proliferation of mucosal layer. It forms like something that is similar web, and if it is too big, patient will have dysphagia. But not always. What is the sign? The sign is also important because dysphagia you might have because of mass formation. For example, cancer. Dysphagia you have in esophageal carcinoma. But in esophageal carcinoma, you have progressive dysphagia, progressive. In the beginning, you cannot swallow, for example, solid food, and later already liquid food has problem. But here in esophageal web, you have dysphagia just for poorly chewed food. Okay, that is also different and important. But what you need to remember about esophageal web, and from hematopathology, maybe you remember Plummer-Vinson syndrome. Plummer-Vinson syndrome is this syndrome, actually. This is collection of symptoms. You should, for where you should find triad. What is a triad? Iron deficiency anemia, you remember iron deficiency anemia. If you find along with the esophageal web and beefy red tongue, this is atrophic glossitis. That means patient has Plummer-Vinson syndrome. This triad means wherever you recognize this triad, that is Plummer-Vinson syndrome. And in postmenopausal women, you find in male usually it's not common. Diverticulars are also a high topic in GI because we find different types of diverticular, okay, and you need to memorize this name. Zenker diverticulum and Meckel diverticulum are two you need to memorize, and don't forget it after passing the exam, okay. Also, what you need to know about diverticular can be true and false, and I will ask, what is the difference between true and false? True diverticulum means actually when you have protrusion of the three layers, okay, you know, in this organ. So we have three layers in the GI tract, right? Mucosal, muscular, and serous layer, right? And these three layers should be protruded. But in false diverticulum, only mucosa protrudes. Only mucosa protrudes in the upper esophagus. Location, upper esophagus is important. If you find this protrusion in the upper esophagus, most likely it will be Zenker diverticulum. And Meckel diverticulum you find in the small intestine, okay? And Meckel diverticulum is true diverticulum because it is lack of involution of venous duct. But in second Zenker diverticulum, it's just false diverticulum, only mucosa is protruding there, and it forms such sac, right? And clinically, how do you know? On X-ray, definitely in upper esophagus, that is really important, okay? Upper esophagus. Halitosis is bad breath, okay? When rotting food in diverticulum usually gives terrible breath. Dysphagia, for some reason, they have dysphagia as well, and obstructions you might have, okay? It depends on location and grade of this diverticulum, okay, how big and how small it is. So halitosis is more common, definitely halitosis you should find. Now let's go down, okay, that is atresia, that is web you find, you can find somewhere around this area. You should know here with this triad, iron deficiency anemia, this web and beefy tongue, that is important. And in any board exam, you will find this question, okay? In any like USMLE or MCI or whatever, these all are really high yield topics. Then we go down and go to the gastroesophageal junction. At this junction, we find different type of lesions. One of the lesions that is really important is Mallory-Weiss syndrome. What is Mallory-Weiss syndrome? Usually you find it in alcoholics, okay? Because it is laceration, longitudinal laceration. You see laceration, and actually you will find blood vessels are damaged here. Blood vessels are damaged because of laceration. And you find it in alcoholics, that is one thing. At this junction, the location is important, guys, and cause vomiting, usually alcoholics or bulimia. Vomiting, guys, vomiting, you know, right? Why do you have vomit? They vomit blood, literally. And you see here painful hematemesis. That is important clinical sign because hematemesis we can have painless as well, okay? Painless and painful. You always pay attention. If patient vomit blood, you always observe, is it painful or does he mention anything like a pain? And if it is painful hematemesis and consumed a lot of alcohol, it's not necessary patient to be alcoholic. Okay, just for a long time, if patients just take alcohol, it can lead to this laceration. Okay, and what happens? Painful hematemesis, just memorize, and risk of Boerhaave syndrome. Boerhaave syndrome is here important. We don't have many medical emergencies, as you know, but one of the medical emergency that you immediately need to make surgery is Boerhaave syndrome. And what is it? It is actually a rupture. Okay, esophageal rupture. You have laceration here, and what can happen? Esophagus can rupture, and what will happen? This air will end up in the mediastinum, and it will give a sound. You literally will find air under the skin. Subcutaneous emphysema, you will find it will make sound, okay, crepitation sound, and you know if you don't make surgery, it will lead definitely to death. Okay, so Boerhaave syndrome is complication of Mallory-Weiss syndrome, and it is actually rupture of esophagus. Okay. The next condition, like what we need to make differential diagnosis between painful hematemesis and painless hematemesis, right? Painless hematemesis you find in esophageal varices. It looks like this. In lower part of esophagus, you will find these dilated varices, blood vessels, veins, okay? Submucosal veins. And here what you need to pay attention. You see portal hypertension. What students usually make mistake in is they in some complex cases. Not I mean just you might have an unclassical case, right? They make the mistake between Mallory-Weiss and esophageal varices. Okay, and why? Here you need to pay attention. Mallory-Weiss syndrome is not related to portal hypertension. Okay, if patient has portal hypertension, they always have this esophageal dilated veins, esophageal veins, and it is esophageal varices. Okay, if you find portal hypertension, guys, don't write Mallory-Weiss syndrome there. Don't think about Mallory-Weiss syndrome. It is possible that both patients can be alcoholic, but still pay attention to the portal hypertension. No, why anatomy here is explained, and I believe you know it. And epidemiology, you also know it. It is most common cause of death. Most common cause of death in cirrhosis. Okay, because cirrhosis lead to portal hypertension. And what is the risk, guys? When you have dilation, it might rupture. Okay, this blood vessel will rupture, and it will lead to severe hemorrhage. Okay. The presentation asymptomatic, you never know actually, patient has anything, no pain at all, nothing, and present the painless hematemesis, and that is actually what will lead to death. Okay, so painful hematemesis and painless hematemesis. It has usually history of drinking, okay, or bulimia, for example, severe vomiting. And in this case, you don't have any symptoms. This is just asymptomatic. And the cause of death is most common cause of death in what I said, cirrhosis. Yes. Next condition is achalasia. It's a kind of You know it is common. I would say it is common. Here, pay attention to Chagas disease. Okay, that is high yield Chagas disease, because achalasia usually you find with secondarily to Chagas disease. They are related, and why? It is a disordered esophageal motility is written here. And what is the problem? You see big bird beak sign on X-ray. That is important. Bird beak sign. Like in respiratory pathology, we had a lot to memorize, okay, about this X-ray. But here you need to memorize this bird beak. And what this is a dilation of esophagus, and here is constriction. And why it happens? Actually, you have problem with relaxation, okay? Inability to relax the lower esophageal sphincter. And if it does not relax, what will happen? You have this stricture formed, okay, narrowing of the esophagus, and food will accumulate here in the upper part. That gives appearance of bird beak. What clinical manifestation, guys, are you expecting? Halitosis will be there, terrible smell, you can't imagine. Dysphagia of solid and liquid food, both. And I wanted you to pay this attention to this sentence, okay? And why? Dysphagia in solid liquid food, you can find in cancer as well, okay? Esophageal cancer. And for some reason, I don't know students, if they know that, read somewhere dysphagia solid of liquid food, they choose cancer. But you see, you have achalasia as well, where you have problem of swallowing liquid and solid food. Why? You have problem in the relaxation of this lower esophageal sphincter. And what it happens? Pathogenesis, you should know, guys. Pathogenesis, ganglion problem. You have damage of ganglion cell in myenteric plexus. Where else in GI tract you will find such condition? Hirschsprung disease. We have Hirschsprung disease. You find in the newborn babies. Okay, newborn babies, and here the same problem actually. You lack these ganglion cells, and the in sigmoid part, rectosigmoid part, you have this dilation of the colon, and it leads to if you don't make surgery, patient might die. This baby might die because of megacolon. Here, same thing. Actually, if you don't have these ganglion cells, and for that reason, it's impossible to relax. Chagas is important. Chagas association, it is idiopathic. Usually, idiopathic cases are really rare. If you find achalasia, it's more likely related to Chagas disease. Bird beak appearance, you will find dysphagia, putrid breath, that is halitosis actually is very logical. And high pressure, esophageal manometry. In this part, pressure is really high. Okay. Complication, increased risk of squamous cell carcinoma. In GI tract, guys, also you need to pay attention. Risk when you have risk of squamous cell carcinoma. In esophagus, for example, where is increased risk of carcinoma, squamous cell carcinoma? Esophageal web. You remember, that is one thing. Another thing is achalasia. Okay, these two definitely have high risk of developing esophageal carcinoma, and other risk factors we have as well, like chemical damage of esophagus can lead to carcinoma. But disorders that are precancerous are usually esophageal web and achalasia. GERD, that is also not how common you know. Usually you find it in fat people who eat a lot, okay, drink a lot. It has risk factors as well, hiatal hernia, alcohol, tobacco, obesity, and caffeine. From this, actually important is hiatal hernia. In Golian is explained this, I don't know which page it is, but in Golian you have explained hiatal hernia. You have two types of hiatal hernia, if I have a picture. No, here's not. Two types of hiatal hernia we have, sliding and paraesophageal. and sliding is more common. Okay, and in both cases, you have also risk, especially in cell sliding one, you have a risk of developing squamous esophageal adenocarcinoma. Okay, just read this hiatal hernia, that is important. Okay, that type of herniation is a high yield in GI tract. We find in intestines and you find in esophagus as well. And so two types of hiatal hernia there, obesity and ethanol and alcohol. Smoking is risk factor. Clinical features, guys, like everyone, each of you knows, GERD, GERD actually has heartburn. And what is a high yield information? We always, when patient has pain, chest pain and heartburn, you need to make the differential diagnosis. Is it definitely GERD or it is myocardial infarction? Okay, that is important. We always, in clinical practice, you will definitely find this case that when patient has heartburn, and chest pain, you always need to check cardiac enzymes, okay, cardiac enzymes. Also with my mixed asthma, okay, but particularly adult onset asthma, okay, both you can find together. You know, asthma is allergic reaction and you should find it in from childhood, right? But this asthma is adult onset. You might find these clinical cases. GERD is related to asthma, adult onset only, and cough. And damage to enamel of the teeth. You might find this caries, for example. You find caries in this patient. Why? Because of this acid reflux comes out in the mouth and it damages animal. Okay, literally melt away the animal. That in severe conditions. Okay, not often you will find because people take care of themselves, right? And it's very um, advanced stage, for example, of GERD. Complication. This complication is highest yield in general pathology, in systemic pathology. Everywhere you mentioned, you will hear about Barrett's esophagus, and you know what is Barrett's esophagus? Actually, 10%. This is very low percent, but still, but if ever you find Barrett's esophagus, this is precancerous condition. Okay, precancerous condition like esophageal web, achalasia, and Barrett's esophagus. These three conditions, precancerous conditions, we know already. Now, what is Barrett's esophagus? That is inflammatory condition, and morphologically under the microscope, you should find what pathologic feature. If a question is what is pathologic feature of pathologic change of Barrett's esophagus, you should say that it is metaplasia. And what is metaplasia? Metaplasia is replacement of one differentiated type of cell with another type of differentiated type of cells. Here, clue is differentiated type of cell. Okay, it is not immature cell; they are differentiated type of cells. For example, this junction we find in cervix as well, guys. There, I will tell you the hint. This type of metaplasias, for example, squamous epithelium undergoes columnar metaplasia. In GI tract, wherever you find metaplasia, that is dangerous, okay? It might lead to cancer. But in reproductive pathology, in female reproductive system, for example, metaplasia is normal condition, okay? It is not related to developing cancer, but in GI tract, it is quite dangerous. So metaplasia, you find this is squamous epithelium, this is columnar epithelium, and goblet cells, you see, goblet cells. And in junction, if you find this metaplasia, literally metaplasia, you will find a change of the epithelium. That is how we make diagnosis of Barrett esophagus, okay? It's supposed here to be squamous epithelium, but here's columnar epithelium. Adenocarcinoma, definitely you will find. Definitely Barrett esophagus without adenocarcinoma in long term, for example, it might take 5 years, but adenocarcinoma is inevitable, usually, okay? Now, here comes, guys, esophageal carcinoma, and it is really high yield. And why it is high yield? I will tell you that in esophagus, remember esophagus, right? esophagus, no, whole esophagus. Imagine, I don't have picture here. You have upper two-third esophagus and the lower one-third esophagus. In lower part, you have this junction, right? The junction, columnar squamous epithelial junction. It is. And for that reason, if you find tumor in the lower esophagus, always pay attention to location. If you find tumor in lower esophagus, it will be adenocarcinoma. But if you find in upper two-third, okay, the location in the upper and medium, okay, middle part of esophagus, it will be squamous cell carcinoma. So here comes adenocarcinoma and squamous cell carcinoma. You should know epidemiology, okay? In adenocarcinoma, you know, adeno means glands, and most commonly it will it arises from Barrett esophagus, okay, risk factor. It is Barrett esophagus. But in squamous cell carcinoma in upper part, you have different risks, okay? And what is it? Web, do you remember? Esophageal web, that is a Plummer-Vinson syndrome. Also, you can find esophageal injury means, guys, it is related to chemical damage, okay? Chemical damage, for example, some the toxic agents and dyes we have that lead to chemical damage of epithelium. And very hot tea. Hot tea is important because, for example, you will find clinical case where Chinese patient has this esophageal mass, and there will be mentioned that he drinks a lot of hot tea. You should ask how hot tea or something they drink. Very hot. The Chinese people literally boiling water drink. That definitely lead to damage of the epithelium. So one of the risk factors is hot tea. Okay, that is important. So achalasia, esophageal web, Plummer-Vinson syndrome because of laceration. Okay, you have damage of epithelium, and chemical injury of the esophagus is risk factor. Alcohol, tobacco is like everywhere, and very hot tea is higher. Prognosis is quite poor. Okay, why? Guys, prognosis is defined with this clinical course actually. Later, it gives late metastasis, but as esophagus has too much space to grow, it presents clinically at late stage when it already gives metastasis, local and distant metastasis. For that reason, it has very poor prognosis, and here is given both type. Presents late. It has too much space, and for that reason, as tumor grows, it metastasizes, and as it presents late, it has already metastasized. Presentation, I pay attention. Progressive dysphagia, I mentioned in the beginning. Progressive dysphagia is important here, of solid and liquid food. Where else we found the solid and liquid food? We find in achalasia. You know, like all tumors, you will find weight loss, cachexia, pain. You will find hematemesis because tumor invade surrounding tissue and damages blood vessels. So hematemesis is a common feature here. And squamous cell carcinoma may have hoarse voice. Why you have hoarse voice? Voice change. Voice change in case of squamous cell carcinoma. It is in upper part tumor usually. In upper part of esophagus, if you have tumor, patient has a voice change, hoarse voice, because you have involvement of nerve, recurrent laryngeal nerve involvement. That is the most important, actually, clinical feature of squamous cell carcinoma. No, cough is logical, right? Tracheal involvement, if you have, you will have cough. It is similar to lung carcinoma. Do you remember in lung carcinoma we have pancreas tumor, for example? You have Horner syndrome, okay, because of the involvement in brachial plexus. You might have other paraneoplastic syndromes as well. This is clinical presentation of tumors, okay? And as for esophageal squamous cell carcinoma and adenocarcinoma, both you should know that it is more possible. But when we are talking about horse boils and calf, it is definitely squamous cell carcinoma, and you will find in upper part of esophagus. Okay, that is exception here. Lymph node involvement, you just memorize this upper part metastasized to cervical nodes, middle and lower and mediastinal, and celiac and gastric node. That is location of metastasis, and that is important. All right. That was esophagus, guys. Let's summarize. We talked about congenital anomalies, which most common is esophagus fistula, clinical symptoms. You pay attention protrusion of esophageal mucosa, proliferation of mucosa layer, that is esophageal web, and here comes this triad. Dysphagia of poorly chewed food, that is important. Diverticulum, like here will be question what is the difference between true and false. What is Zenkel, what is Meckel? Clinical signs are here. Mallory waste usually are related to alcoholism, vomiting, but painful. But painful hematemesis we find in esophageal varices, and usually it is associated with portal hypertension. Never ever forget it. Achalasia is high yield. It is precancerous condition. Pathogenesis is important. You have lack of it is not lack. Lack is in Hirschsprung, but you have disordered esophageal motility because of ganglion damage of the ganglion. There is lack of ganglion, and here is damage of ganglion. Chagas disease is high yield association. GERD here in Robbins not, but in Golian, you will see these risk factors are very well explained. And Barrett esophagus, you know already, and carcinoma. Guys, don't make a mistake here, please, that we have adenocarcinoma and squamous cell carcinoma, and you need to make differential diagnosis between them. Okay, what is common between this and what is different? Okay, common, different, and identical. Pay attention to these parts. Okay. So this picture I like actually from Golian in esophagus, what you find in different locations, what type of diseases you are expecting. Okay, this picture I like. But now it is not important. I will carry on with stomach. Just give me 5 minute break because I need it very much. In 5 minutes I will come back.
Sure, doctor.
So guys, I'm back, and we will continue with stomach. Likewise in esophagus, here we start with congenital anomalies, then we start infectious conditions, inflammatory conditions, PUD is high yield PUD, and carcinoma. Okay, that is high yield. Now let's talk about stomach. You know that is anatomy, that is part of the stomach. You need to know what is fundus, body, pyloric antrum, pylorus, duodenum, and esophagus. Okay, cardia and pylorus is different. Why you need to know these guys? Because location or different conditions you find at different location. Okay, and that is really high yield. You will find it in questions. Okay, in all questions, and it is important clinical information as well. Say gastric carcinoma, gastric ulcer, Valery-Weiss syndrome. Yes, I will show you. To start with congenital anomalies, we have many congenital anomalies actually in stomach, but intestine, in Golian you have this information, okay? But pay attention to understand the principle. If you don't know embryology, actually it is difficult to understand, but at least something you will memorize, that schisis is break, omphalo is navel, and seal is swelling. Wherever you find word seal, that means swelling, something like this. Okay? So if you understand this term, you need to know what is gastroschisis and omphalocele. Both are congenital anomaly, and in each case you have problem in anterior wall. Okay, anterior abdominal, anterior wall. And what is the difference between gastroschisis means you have break, okay, schisis means break. That means you don't have absence of anterior wall completely. You don't have wall here. And the whole, so the content is coming out, okay? That is like this. And this is omphalocele is when you have just persistent herniation. Herniation means when the content is relieved, but it has some hernia, okay? It is in some sac usually, this content. And in this case, in the omphalocele, you have omphalocele is the most milder condition compared to gastroschisis. With surgery, child can survive, but unlike this gastroschisis, usually it is impossible to make surgery. Everything there is absence of abdominal wall. For that reason, it is difficult. Omphalocele, persistent herniation of bowel into the umbilical cord. You see, you will find this sac here. This here is schematic, visual, and due to failure of a herniated intestine to return to the body. Yes, I think this is logical, as you don't have abdominal wall, or if it does not close completely, this content will be out. Okay, and this is peritoneal cavity actually, covered by peritoneum. Omphalocele is covered by peritoneum and amnion of umbilical cord. Anyway, guys, these two are important, okay? But you will find minor congenital anomalies, which you might find interesting. But here, memorize that gastroschisis and omphalocele. If you know, you will understand other conditions as well. Pyloric stenosis. Pylorus is here, okay? So what you need to know, pyloric stenosis is congenital anomaly as well, and in this area you will find hypertrophy of pyloric smooth muscle. Sphincter, what is, you know, it consists of muscles, okay, smooth muscles. And what happens actually in this pyloric area, you have hypertrophy of the smooth muscles. For that reason, you will have stenosis, okay? You have stenosis. And you should know, this information is important. Male to female predominance. It is more commonly found in male, okay? Baby boy is born, for example, and most likely there will be pyloric stenosis. And what happens actually? Do you remember in this gastroesophageal fistula, there was vomiting immediately they eat? Here you have this projectile vomiting after 2 weeks, okay, present after 2 weeks of birth. That is important. That is congenital anomaly in the stomach that lead to vomiting, but after birth, after 2 weeks of birth, okay. Clinically, what you find, peristalsis is there. You can feel, literally, you can feel this hypertrophy, olive-like mass on the abdomen, you will feel. And also vomiting, vomiting after eating, and this manifests after 2 weeks usually. And also pay attention, non-bilious is given here. Non-bilious, why? What is non-bilious? When baby vomits, actually, it is white. It is not green, but it is bilious. You will find something like this, okay? Bilious vomiting is green. What is the difference? In duodenal atresia, you will find bilious vomiting. And pyloric stenosis, you will find non-bilious vomiting because bile we have in duodenum, right? And in this case, food actually stops here and cannot go to the duodenum, all right? Cannot pass the duodenum. So you have stenosis, guys. Again, in after 2 weeks, you start vomiting. You feel like mass, this olive like mass, non-bilious vomiting, and that is a male predominance. In male newborns, you will find it. How are you going to treat? Any congenital anomaly can be treated with surgery. Myota may cut this pyloric, this area, this hypertrophic area. You will cut out, and patient is absolutely normal. Okay, they can live without any complications. That is about congenital anomalies, just gastroschisis, omphalocele, and pyloric stenosis. Pay attention, non-bilious vomiting, and after 2 weeks, okay? That olive mass, if you find, definitely very easy to make diagnosis. So it is easy to make diagnosis of pyloric stenosis, and you should do this operation, myotomy. Now comes these inflammatory conditions of the stomach, and like everywhere, inflammation can be acute and chronic. So gastritis is inflammation. Itis means inflammation. Gastritis you will have acute and chronic. What you need to know now. What is pathogenesis differs? Okay, pathogenesis differs, and in acute gastritis, pathogenesis is imbalance between production of acid, okay, production of acid, or prevention of mucosa, the protection of mucosal layer, okay? Either you have overproduction of the gastric acid, or this mucosal layer is not protected, okay? It is imbalanced, like it is similar to lung. Do you remember? For example, COPD, when we are doing this COPD, there were imbalance between proteases and antiproteases, and as you have the overactivation antiproteases, proteases, it will lead to emphysema, right? Similar things happen. Actually, balance is important. Either you should regulate production of gastric acid, or you should protect this mucosa, gastric mucosa. Now, in acute gastritis, these two mechanisms you have. But in chronic gastritis, you can have two types of chronic gastritis. One is autoimmune condition, and another is infectious condition. Okay, autoimmune is acute atrophic gastritis. Okay, chronic gastritis, atrophic one, autoimmune one, and another is Helicobacter pylori gastritis, infectious. I mentioned, right? Now, that is the pathogenesis of these two. What happens? Chronic inflammation of stomach mucosa, that is chronic. This is acute inflammation, acidic damage occurs. So pathogenesis is either overproduction of gastric acid or defense against acid we don't have. How it occurs, how we protect our mucosa. One is mucin production, guys. Mucin production by these favela cells. So favela cells is epithelial cells we have in stomach, and they produce this mucus, and this mucus protects this layer. Bicarb secretion, that is also another protection. Blood supply is also another mechanism, because blood supply provides nutritional agents, and it helps to recover this epithelium, right? So at its level, if you have problem, for example, if you have problem with favela cells, if you have problem with bicarb secretion, or if you have hypovolemia, for example, disturbance of blood supply, you are at risk of developing acute gastritis. Okay, etiologies now, and I will talk about etiologies in acute gastritis. What can cause, guys, gastritis? One is severe burn. What is severe burn? Severe burns can lead to gastritis and finally ulcers. You see here Cushing and curling ulcer. These two are really important. Question is, when you find curling ulcer and when you find Cushing ulcers, and how are they related? Okay. For example, severe burn, how can cause gastritis and rather ulcer in the stomach? What happens actually is in severe burn you have loss of blood and fluid, right? Hypovolemia, you have hypovolemia, and because of hypovolemia you have loss of blood supply to the stomach, and it will lead to Cushing ulcer. Okay, in this case, okay, if you find acute gastritis with ulceration after severe burn, that is called curling ulcer. Now, what is Cushing ulcer? Increased intracranial pressure. How is increased intracranial pressure related to stomach inflammation, for example, okay, or ulcer formation? Actually, what happens is, in this case, you will find, guys, car accident or trauma or something, okay, head injury you should have, and because of head injury, you might have this increased intracranial pressure, and it increased vagus stimulation, okay, it increased vagus stimulation, and for that reason, increased production of the increased production of gastric acid. Okay, what happens, increased production of gastric acid, and for that reason you will have gastritis with formation of ulcers, and this ulcer will be Cushing ulcer. So differential diagnosis after trauma, in case of trauma, head trauma, you will find Cushing ulcer, and mechanism is increased intracranial pressure, and in case of severe burn, because of you will have curling ulcer, and the mechanism is hypovolemia. So NSAIDs, you know already, because it decreases prostaglandins, and prostaglandins actually protect our mucosa. Mechanism, you know. What happens in chemotherapy? Chemotherapy is important, particularly after leukemia. Okay, leukemia patient has this gastritis because of chemotherapy affects cells that proliferate fast, right? And the mucosal epithelium of the stomach has this highly proliferative potential. It recovers easily. For that reason, these mucosal epithelium are very bad affected after chemotherapy. So it's very, very common complication of chemotherapy to get severe gastritis, okay? And sometimes you can have ulcer. What happens in shock? Shock is severe hypertension. You know, with severe hypertension, for that reason you will have ischemia to the stomach. And in case of shock, guys, you have multiple stress ulcers, okay? So 3 types of ulcers you can have in case of acute gastritis: curling ulcer, Cushing ulcer, and here is not multiple stress ulcers. Multiple stress ulcers you find in shock, and the mechanism is actually hypertension and hypovolemia as well, right? And multiple ischemic areas you will find there. Heavy alcohol consumption is very logical, because alcohol directly damage any epithelial cell. Okay, alcohol is respected everywhere. In chronic gastritis, as I mentioned, chronic autoimmune gastritis, we have autoimmune means you have autoantibodies against parietal cells, and in another type is chronic Helicobacter pylori gastritis. That is also important. I will talk about it. How to differentiate actually So you know we have acute and chronic gastritis. You should know etiology and pathogenesis, and then you need to talk about what is chronic gastritis and how can we differentiate these two types of chronic gastritis, autoimmune and Helicobacter. Guys, also in acute gastritis, I forgot to mention what type of damage on the epithelium you find. Okay, you might have superficial inflammation, or you might have erosion, and you might have also. What is the difference between them? Erosion again is superficial, that is limited to the only epithelium, and in case of ulcer, macellar layer and macellaris propria or macellar layer can be involved. And as a consequence, after erosion, you don't have scar formation and fibrosis, but in case of ulcer, you always have scarring and fibrosis. Okay, that is the major difference. And that's how we differentiate this damage grossly and microscopically. Now let's talk about autoimmune gastritis and chronic Helicobacter pylori gastritis. Here, guys, I will tell you what you need to pay attention to. Uh, Type 4 hypersensitivity, like it is autoimmune disorder. For that reason, you have type 4 hypersensitivity, it is T-cell mediated. Question is, against what do you have these autoantibodies? Autoantibodies are against parietal cells. For that reason, where do we have parietal cells? Parietal cells we have in this area. Okay, in this area, like it's given here. Acute erosive gastritis you can find here. Gastric ulcer you find in body as well. Mallory waves here. Actually, it is not good picture, so I will return to this. Pay attention, my darling, that parietal cells are damaged. For that reason, in this area, in the fundal area, I particularly this area, you will have atrophy, okay, atrophy of the stomach. So that's why it has name atrophic gastritis, okay, autoimmune acute gastritis. And what happens, the atrophy, yeah, it's given here, atrophy of mucosal. And guys, intestinal metaplasia here and here. What it means, I already mentioned that wherever you find metaplasia in GI tract, that means there's increased risk of cancer. And what type of cancer? Intestinal adenocarcinoma, okay? Because you have intestinal metaplasia. Why it occurs? Because of inflammation. It is gastritis, it is chronic inflammation. And to protect actually this mucosa, this is adaptation reaction, right? You know from general pathology that metaplasia is adaptation reaction and there's replacement. What type of metaplasia you find? Intestine-like cells will be found in stomach, okay? I like this. In stomach, you are not supposed to find these goblet cells. You should not find these lymphocytes. On the background in the stroma, you find multiple lymphocytes. Lymphocytes you're supposed to find in intestines, but you're not supposed to find them in stomach. But if there is chronic inflammation, you will find lymphocytic infiltrate, and this is intestinal metaplasia. Okay, that's one. In both cases, either it is autoimmune or Helicobacter gastritis, in both cases you find metaplasia. Why? Because in both cases you have inflammation, chronic inflammation. You have increased risk of adenocarcinoma of this intestinal type. Okay, intestinal type. Like in esophagus, we have two types of cancer: squamous cell carcinoma and adenocarcinoma. In stomach, we have also two types of cancer. If it is epithelial cancer, or if it is carcinoma, you will have intestinal and diffuse. But we have other three types of tumors as well, malignant tumors, and I will tell about it as well. Echlorhydria, that's a clinical features. Echlorhydria, why echlorhydria? Because there is no gastric acid because of parietal cell damage, okay? No gastrin. And G-cell hyperplasia, echlorhydria and G-cell hyperplasia, this is adaptation reaction, guys. If you have low acid, guys, G-cells usually proliferate. It is similar to chronic bronchitis. Do you remember in chronic bronchitis you have hyperplasia and hypertrophy of mucosal glands, and it is to protect this bronchial epithelium. Same mechanism actually here, okay? Megaloblastic anemia is really high yield, and it's from hematopathology. You remember megaloblastic anemia is a B12 deficiency anemia, okay? And pernicious anemia is in severe cases, okay? Lack of intrinsic factor, it needs to absorb B12 deficiency. That's why chronic autoimmune gastritis is associated with actually clinical manifestation is megaloblastic anemia. They usually exist together. Megaloblastic anemia because of B12 deficiency. G-cell hyperplasia under the microscope, pathologic change will be G-cell hyperplasia, you will see. Clinically, you will find achlorhydria, and morphologically, you should find as well intestinal metaplasia and grossly atrophy. Okay, grossly atrophy. Laboratory finding, you see antibodies you should find. It is very logical because it is autoimmune disorder. And antibodies against intrinsic factor as well, intrinsic factor. What you need to know is Helicobacter pylori. The location, guys. Location, this is important here. Where you usually find Helicobacter pylori? Helicobacter pylori, you find in prepyloric area, okay? Prepyloric and antrum. I literally at this area you will find usually Helicobacter pylori. And during the gastroscopy, do you remember, you swallow this tube, and they observe the mucosal epithelium, and finally they take biopsy from this area. You cannot find Helicobacter pylori from anywhere else, okay? From fundus or body. The Helicobacter pylori usually are not found there, only in this area, prepyloric area and antrum. Okay, so location is important. Helicobacter pylori is there. Now, clinically, you will find epigastric pain. You don't have epigastric pain here. In chronic autoimmune gastritis, you don't have epigastric pain, but in Helicobacter pylori, you haven't. I will tell you why it is important, okay? Increased risk of ulceration. Ulceration is very, very high yield, especially in long term. If you are Helicobacter pylori positive, you definitely need to treat because it will lead to ulcer, and finally, there is very high risk of developing adenocarcinoma. Guys, you will read in Golian, you have how to make diagnosis of the Helicobacter pylori, different tests we have. It is very interesting. That is also there. And I want you to pay attention to this part, maltoma. You remember, and what I'm talking about now, that is very high yield. I will ask this question. I will show the case, and please don't make mistake there. I'm going to put it in exam as well. So increased risk of gastric adenocarcinoma, intestinal type. That is one complication. And here you have increased risk of intestinal type as well as maltoma. Maltoma is lymphoma, guys, lymphoma that you find in this GI lymphoid tissue. Why it happens usually? In chronic, you know, guys, intestinal metaplasia is there. You know, you have increased risk of adenocarcinoma. But in case of Helicobacter pylori gastritis, you find this lymphoid hyperplasia as well, lymphocytic infiltration you find. And there, as a complication, there is increased risk of developing not only adenocarcinoma, but lymphoma. How do you know now it is lymphoma? Don't get confused. This case, what I'm going to show you, it's quite complex. Only thing you can make diagnosis, guys, is morphological examination, okay? Morphology. And the final diagnosis is always made by pathologist based on morphologic and immunohistochemical changes. You should find, you might find pleomorphic cells, or you might find monomorphic cells, like monomorphic cells, you know, if it is usually tumor adenocarcinoma, it's pleomorphic. Like you have increased nuclear to cytoplasmic ratio, you have different size and shape of cells. But if it is lymphoma is uniform. You just small blue cells you will find, right? And you pay attention to the architecture and morphology of the cell. And also, you should pay attention to immunohistochemistry. All lymphoma cells are mucosa, they don't, epithelial cell produce mucosa, and this lymphoma cell does not produce mucosa, okay? For that reason, the marker will be negative for that. And they might mention immunohistochemical markers that only show, that does not show epithelial, and either it will show mesenchymal markers or it will show lymphoid markers, but not definitely epithelial markers like keratin and mucosa interaction will be negative. So why I'm talking about it? Please make differential diagnosis if case is about tumor, malignant tumor. Make sure, is it lymphoma, is it adenocarcinoma, is it benign, is it stromal tumors, okay, GIST, G-I-S-T, that is type of tumor, or it is neuroendocrine carcinoid tumor. Okay, these possibilities we have in stomach: adenocarcinoma, lymphoma, carcinoid, and GIST, GIST, stromal tumors, mesenchymal tumors. GIST usually can be benign and malignant. So maltoma, I to try to emphasize here, maltoma is really high yield, and usually you find it in case of Helicobacter pylori. Now, guys, here was mentioned increased risk of ulceration. Okay, pay attention. Increased risk of ulceration. It happens only in case of Helicobacter pylori, but not autoimmune gastritis. As you have increased of ulceration, now goes to peptic ulcer disease. Peptic ulcer disease means wherever you find ulcer. Ulcer, based on location, can be two types. You might find ulcer in duodenum or stomach itself. Okay, gastric ulcer and duodenal ulcer you have. This is really high yield. A lot you need to know to make differential diagnosis. Pay attention to the solitary mucosal ulcer. That is how you make diagnosis on stress ulcers. Stress ulcers are usually multiple, and you find it in shock. And this peptic ulcer disease is usually solitary, only one you find, and usually you find in proximal duodenum or distal stomach. Pay attention to this number, 90% and 10%. It means that most likely if you find PUD, it will be duodenal, okay, duodenal, 90%. Now, another information, 95-75, pay attention to this. Duodenal ulcers, in 95% is due to Helicobacter pylori, okay? But 75 is due to Helicobacter pylori in gastric ulcer. Both is high number, guys, but pay attention to this part, okay? 90 and 10. Gastric stomach ulcers are quite rare, all right? So if you have a case where a patient has Helicobacter pylori, most likely it will be duodenal ulcer, not gastric ulcer. In gastric ulcer, you have completely different risk factors, and I will tell you now why. In both cases, you have Helicobacter pylori, but in clinical practice, if your patient has Helicobacter pylori, think about duodenal ulcer first. Now other causes. You see, rarely due to Zollinger-Ellison syndrome. This is neuroendocrine type of tumor of pancreas, okay, neuroendocrine. And as you have gastrinoma, if I remember, this is gastrinoma, and it leads to formation of duodenal ulcer, okay? That is second, very rare, actually. This case is rare, but you should know that it is one of the risk factors, okay? If patient has Zollinger-Ellison syndrome, definitely you will have ulcers, but this disease itself is very rare. Now what happens? Gastric ulcer is related to NSAID use, So pay attention. Is it pile? Most likely, if we are talking about gastric ulcer, cause is NSAID use. Okay, NSAID use of bile reflux, and 75% is Helicobacter pylori, but you don't find many clinical cases about it. You should just know that if patient has Helicobacter pylori, there is increased risk of ulceration. But if the question is about differential diagnosis between duodenal ulcer and gastric ulcer, you need to pay attention to more details, okay? Now, presentation, epigastric pain that involves with meal, that improves with meal and worsens with meal. Now, what is the meaning? You will see patient who is slim and who is fat, okay? And why? Usually this with meal, who I worsen with meal, they don't eat, okay, because they have fear of pain, and you will observe a weight loss here. And as you hear weight loss, you know that it is usually associated with the tumor, right? Cancer, for example. But this patient lose weight. But it is because of they cannot eat because they have fear of pain, as they have epigastric ulcer, and it leads to pain with meal, and it improves with meal. So for that reason, they constantly try to eat. And now, what is the idea behind it? If it is gastric, you know, when you eat, you have a gastric acid production, and it irritates the mucosa. And here, this in duodenum, actually bicarb production we have, right? And when you eat in duodenum, you have production of bicarb, and it neutralizes the acid bulb from the stomach when it receives. For that reason, it improves with meal. After meal, you have the increased production of bicarbs in duodenum, and it eases the pain. Location, mostly in anterior duodenum, mostly in lesser curvature. Here comes acute gastritis, both lesser curvature. You see, lesser curvature, that is a classical area. Usually. Location helps actually, but you can find anywhere else, okay? But mostly is keyword here. Most likely and mostly anterior duodenum is here, and here lesser curvature. Guys, here is anterior duodenum, but what happens in posterior duodenum now? It is rare. Rarely you find in posterior duodenum, but complications usually you find in that case, okay, in the posterior duodenum. But if ulcer is in it's here. In posterior duodenum, you can have rupture and bleeding. Okay, perforation is very common complication in that case. Actually, guys, it is important clinical information you will find in your clinical practice when you become a doctor. So memorize. Common location is anterior duodenum, but if you find in posterior duodenum, there is increased risk of complication like rupture and bleeding and so on. Okay, so risks, you pay attention to the risk. That is important information. Biopsy, ulcer with hypertrophy of Brunner glands. Here the same as chronic bronchitis, guys. Okay, in ulcer, duodenal ulcer, you find actually hyperplasia and hypertrophy of the Brunner gland. Brunner gland you find in this duodenal epithelium, and they produce this bicarb, right? And to protect this mucosa somehow, it undergoes hypertrophy. Like in chronic bronchitis, you have hypertrophy of the mucosal gland to produce a lot of mucus. But there it causes damage. COPD it causes. Here we don't have such condition, but diagnostic feature actually. Increased hypertrophic Brunner glands is sign of duodenal ulcer. Risk of carcinoma, that is important information. You remember in chronic and chronic, these two types of chronic gastritis we have, and in both cases you have risk of carcinoma. But in this case, if you make differential diagnosis between duodenal ulcer and gastric ulcer, in duodenal ulcers, you never have cancer, okay? You might find malignant proliferation there, and most likely it will be carcinoid. Okay, carcinoid tumors in small intestines. Usually, you don't find malignant tumors, guys. You find malignant tumors in colon. In small intestines, adenocarcinoma is such thing we don't have extremely rare it is, but carcinoid tumors which you might find. So duodenal ulcers almost never are malignant. Okay, but gastric carcinoma, here comes important information. You need to. It can be malignant. Gastric ulcers can be malignant. So for that reason, you need to make the differential diagnosis between benign and malignant ulcer. Okay, benign gastric peptic ulcer, malignant gastric peptic ulcer. In this case, forget duodenal ulcer never undergo malignant transformation. So it is very common for that reason. It is not dangerous condition. But if you find gastric ulcer, you must make differential diagnosis. Is it benign or is it malignant ulcer? Now what happens? It may be caused by gastric carcinoma, and that's why. You see these two images. Actually, by appearance, you should differentiate them. If you have benign peptic ulcer, usually it is small. You know general features of how to differentiate benign and malignant lesions. Benign is usually small, well circumscribed, three borders it has, but malignant is irregular. You see, it is uglier, and this is smooth and small. Okay, so this is malignant, this is benign. It is very logical. Less than 3 centimeter. Pay attention to this information. Less than 3 centimeter is usually benign one. Sharply demarcated, punched out, and surrounded by radiating folds of mucosa. And that is nothing important. And this is usually large, and it has hip-top margins. You see, hip-top margin. That is important information. Usually, it is frequently asked on board exam, and how important clinical information you can guess it. Okay, gastric ulcer can be caused because of gastric carcinoma. For that reason, you need to make differential diagnosis. That is PUD, guys. Like revise peptic ulcer disease, duodenal and gastric. 90% very common. Helicobacter pylori is a major risk factor. Clinical presentation with meal and I think it worsens or improves. Okay, that is also important. Location and risk. And this appearance you will know, and you will find many pictures in colon. Gastric adenocarcinoma, guys. I mentioned, and I will repeat that 4 types of tumors you need to expect in stomach, and 75% is adenocarcinomas. Actually, 10% I think is lymphomas. Okay, so lymphomas you can find as well. And we have carcinoid tumors, and we have, this is very rare. Carcinoids are very rare, and cysts are also very rare. Stromal tumors. As it is most common, adenocarcinoma, as it is most common, we need to talk about it. So adenocarcinoma, as I mentioned already, are 2 types, intestinal and diffuse. Intestinal is more common, and you find it in case of risk factor. What is risk factor is chronic gastritis, okay? You know, but you can have it can arise de novo as well, okay? But diffuse type is de novo usually. It does not have precancerous condition. Presents, guys, with presents late. For that reason, it has very poor prognosis, weight loss, abdominal pain, anemia, and early satiety. Here, pay attention to early satiety, okay? Early satiety, wherever you hear, it is related to stomach mass, okay? You will find stomach mass. And what you need to know, really, paraneoplastic syndrome.
According to Healthline, an abdominal mass is an abnormal growth in the abdomen. An abdominal mass causes visible swelling and may change the shape of the abdomen.
Phone is talking about abdominal mass. It listened what I was talking. It is very funny. So, my darling, diffuse type and intestinal type, paraneoplastic syndromes. in the lung carcinoma. Many paraneoplastic syndromes were there, but here very few. Actually, you need to memorize lacetrelate sign. Usually it is seborrheic keratosis. Seborrheic keratosis, in normal condition, if it is normal, it should be solitary. Okay, solitary, only one, and usually you find on face most commonly, and in elderly patient. But if you find all of a sudden whole back is covered with multiple seborrheic keratosis, that is sign of lacetrelate, and it is paraneoplastic syndrome of gastric carcinoma. So it is dangerous condition. Whole back, whole body is covered with this seborrheic keratosis. So that is lacetrelate and paraneoplastic syndrome of gastric carcinoma. Acanthosis nigricans is not specific, but acanthosis nigricans, it is said that it is hyperplasia and darkening of the epidermis, and it is known as paraneoplastic syndrome of gastric adenocarcinoma. But acanthosis nigricans also you find in Cushing syndrome, you find in diabetic patients, so it is not specific to gastric adenocarcinoma. Metastasis is really high yield, and you should never ever forget cystic Marie-Joseph nodule and Krukenberg tumor. These two. What it means? That is really high yield because it is secondary ovarian carcinoma. And it is always bilateral. And if you find sometimes gastric carcinoma manifest, clinical feature is this, okay? The patient comes to you with bilateral mass in both ovary. And you need to make differential diagnosis. Is it primary ovarian carcinoma or secondary ovarian carcinoma? This is secondary ovarian carcinoma, and primary source is stomach. Always, guys, it is very, very high yield. Favorite questions on exam. And pay attention to this intestinal type and diffuse type. Intestinal type gives this type of metastasis, and diffuse is of a Krukenberg tumor. Krukenberg tumor is secondary ovarian carcinoma, and it is diffuse type of gastric carcinoma. And cystic Marie-Joseph nodule is periumbilical metastasis. Okay, these two metastases is really high yield. I will ask it, and make sure it is really important, metastasis. If the question is where usually stomach cancer metastasize, most common places will be mentioned, and most commonly it metastasizes to the local lymph node, okay, local lymph node, then it metastasizes to the liver. Here is given most common, but most common is actually local lymph node, then goes to lymph node, and then goes to distant metastasis. And distant example of distant metastasis is this cystic Marie-Joseph nodule and Krukenberg tumor. Krukenberg was doctor who discovered this secondary bilateral ovarian carcinoma. Now, guys, differential diagnosis between intestinal and diffuse. You should make differential diagnosis based on gross appearance, okay? Gross, I will ask you grossly how they look, microscopically how they look, and what is the location and risk factors, okay? But gross and microscopic examination is very important. Gross picture you see here. Intestinal type more common is than diffuse type, but if question is which is worse, diffuse type is worse, okay? It proliferates really fast. It is very undifferentiated tumor and does not respond well to the chemo radiotherapy, okay? Why? Because it is very anaplastic tumor it is. As you see picture, it is irregular ulcer. It manifests intestinal type, usually most commonly manifest as ulcer, okay, with nerve margin. This is irregular, big in size. You understand? And what you see, this is this thickened, a thick wall you find. This thick wall actually means linitis plastica. Pay attention, linitis plastica is gross manifestation of diffuse type of tumor. And it happens because of desmoplasia. Desmoplastic reaction is a reaction what we find in malignant tumors, and it means actually proliferation of stromal tissue, okay? Proliferation of fibroblasts, and they lay down this fibrous tissue. and the tissue itself becomes very thick, leather-like. It means it is. So you see, linitis plastica literally look like this. And if question is, what is the idea behind it? It means in stomach cancer, diffuse type, you find desmoplastic reaction, like guys in breast carcinoma. Okay, so we don't have many organs with desmoplastic reaction. One of the tumor is stomach, and is also breast and prostate. It makes tumor really hard. Okay, so that is linitis plastica here. Here you will find ulcer. Now goes to the microscopic examination. This is adenocarcinoma. I don't have a picture here, but what you are supposed to find, glands, guys. Glandular proliferation would be here, and linitis plastica is very different, and you should know that signet ring cells. Wherever you find signet ring cells, we don't have only in stomach. Signet ring cell in general is sign of undifferentiated tumor. Okay, undifferentiated tumor. And you might find in the ovary, in the intestines, everywhere you can find actually, and it is sign of undifferentiation. But in linitis plus signet ring cell carcinoma, we have also this tumor with this name, signet ring cell carcinoma of stomach. And that is diffuse type of tumor. And diffuse, why? Because they grow diffusely, infiltrate, and very, very highly proliferative tumors they are. Signet ring cell, like it's a punched out nuclear you will find, and cell is full of glycogen. Multiple signet ring cells you will find there. So if you find this microscopic image, guys, that means it is very malignant, poor prognosis, and patient won't survive for long. Risk factors, again, lesser curvature of gastric atrium is location. That is, you know already. And risk factors, intestinal metaplasia, Helicobacter pylori, and autoimmune gastritis, remember already. And nitrosamine. It's very logical. Do not eat smoked food, guys. Too much smoked food, because this nitrosamine actually lead to mutations in some genes, molecular pathways, and it will lead to formation of cancer. Where you find this high risk of gastric carcinoma? In Japanese population, because they consume a lot of smoked food. Here is a de novo, as I mentioned. This diffuse type carcinoma does not have any precancerous condition, but you know, if patient is very unlucky, they will have this carcinoma. That is about our stomach. Stomach is really high yield. Many questions you have, clinically very high yield and informative. You see a lot of things. Differential diagnosis you need to make. You need to compare many things, acute and chronic gastritis. Then in chronic, what is between chronic autoimmune and pyloric gastritis. Then pyloric gastric ascites, chronic pyloric gastritis will lead to peptic ulcer disease. Here, based on location, you have duodenal and gastric. You need to make diagnosis. Then in gastric, it divides with two, like malignant and benign. Also, you need to make differential diagnosis. And when it comes to tumor, you have two types, intestinal and diffuse, okay? And in tumors, you need to differentiate also adenocarcinoma and lymphoma. You see, stomach is quite big portion, and you need to prepare it well. Now, whatever I manage now to talk about small bowel, I will tell you. Duodenal congenital anomalies, again, duodenal atresia, pay attention. Failure duodenum to canalize. Down syndrome is important because Down syndrome actually is disease where you find many associations, right? You remember some leukemias are associated with Down syndrome, and in GI tract, Down syndrome is related to duodenal atresia and Hirschsprung syndrome as well. So Down syndrome, memorize here. Bilious vomiting. Why do you need to know bilious vomiting? You need this way you will differentiate from pyloric stenosis, and you will differentiate from this esophageal atresia. Okay, so there is non-bilious, and here is bilious vomiting. Polyhydramnios because atresia. In the beginning, I mentioned this, and distension of the stomach, and this X-ray sign is important. Okay, distension, blind loop of duodenum, as well as distension of stomach. You will have that is very logical and nothing important and philosophical here. Mecal diverticulum. Here comes comparison between Requiemus Zenker and Mecal diverticulum. One is true, another is false. You will read it. Pathogenesis and stuff. Rule of two. It's interesting. How big it is. You should know how far it is from ileocecal valve. That is important and present within first 2 years. It is benign condition. It does not have any risk of carcinoma or anything, nothing. Just you need to make surgery, okay? But if you don't make surgery, I know many people live with mecal diverticulum, okay? And it presents with first 2 years of life. Actually, it depends on grade as well, how big is diverticulum. Presentation asymptomatic, you see, is sometimes can bleed, sometimes just. Anyway, guys, the congenital anomalies you will read. Herniation, volvulus in intussusception. This is also, very easy topic it is, but you need to know what is the difference. Volvulus is just twisting, okay, twisting, and this is telescoping, okay, twisting, telescoping. And if you have twisting and telescoping, what is the complication is important. In both cases, you have a risk of ischemia and necrosis, right? For that reason, volvulus intussusception and herniation, both, all of them has pain, okay, characterized with pain. Because this one is interesting information in kids. Intussusception you find in kids, and it's related to rotavirus. In kids, usually it's common, okay? Usually it's common because this intestinal infections, you know how common it is, particularly rotavirus. It leads to lymphoid hyperplasia, and as you have lymphoid hyperplasia, in terminal ileum, it will lead to intussusception, and it causes pain because of ischemia, and it needs attention, okay, definitely. Otherwise, it will result to obstruction and infarction. In adults, if you find intussusception, most common cause is tumor. So intussusception is complication of the tumor. You can memorize like this. The features of current jelly stool, you will look it and read. Presentation, clinical presentation is important, and read it. Guys, I want you to pay attention to small bowel infarction and large bowel infarction, okay? This is type of vascular pathology. And what you need to pay attention. Small bowel infarction, memorize this superior SMA, okay? SMA is important. And angiodysplasia. Do you remember angiodysplasia? Maybe we have here. Right. Hirschsprung, diabetes, angiodysplasia, and hereditary hemorrhagic telangiectasia. This is a vascular condition, but in colon. And there was in a small intestine. Angiodysplasia is acquired malformation of mucosal and submucosal capillary beds, and it leads location cecum and right colon, and rupture of capillary bed presents in hematochezia in old adults. Here is important, old adults, okay, old adults. And this part, this one, you will find usually in the younger individuals. Where is it? Younger. But it is similar to cardiac pathology, myocardial infarction. You remember, we have two types of myocardial infarction, subendocardial and transmural. Same here, okay? Transmural infarction and only mucosal infarction. Causes are also important. Why? Because the hypertension might be described, for example, after car crash or something, shock, or any case of hypertension, patient will have mucosal infarction, and it is not severe condition. Hypertension leads cause only mucosal infarction. superficial. And transmural is more severe condition, right? And it is related to thrombosis and embolism. Embolism where? In superior mesenteric artery, and you should know this as well, vasculitis and atrial fibrillation. Vasculitis, which vasculitis? I will tell you. You can have a look, but it is polyarteritis nodosa. Okay, polyarteritis nodosa is medium vessel vasculitis, which which lead to thrombosis in superior mesenteric artery. And what is clinical manifestation? Clinical manifestation, guys, will be pain. Okay, stomach pain most likely is related to ischemia and necrosis. Severe pain you will have, and melena as well. But here is, you see, mesenteric vein as well. So artery can be affected, vein can be affected, but it is vein. Most likely it will be polycythemia vera or lupus. Okay, that is important clinical information, by the way. And if you know this knowledge, then you should be able to improvise it in clinical case, okay, in real cases. So vascular pathologies, angiodysplasia, thrombosis, emboli, which blood vessel, what is clinical manifestation and association, that is really high yield. Now, malabsorption syndromes we have. I don't know. I think it is too much for you guys, but okay, only this part is. You don't need to read carcinoid tumors, and you don't need to read tumors, malignant tumor, colonic adenocarcinoma, and inflammatory bowel disease. Inflammatory bowel disease, actually, guys, I put in presentation topics, okay? Crohn's disease and ulcerative colitis. One of the topics is to differentiate Crohn's disease from ulcerative colitis. And next week, I will talk about it as well. Just here, you need to make differential diagnosis between lactose intolerance, between celiac disease, tropical sprue, and Whoop disease. Okay, these four, you need to compare each other. What is similar, what is different, and what is identical. Lactose intolerance, you know, it is very logical. You have absent or hyperfunction of lactase enzyme. Okay, and where you have it is brush border. All right, and here I want to pay attention to congenital and acquired. That is different. That's important. It can be congenital, which is quite rare, autosomal recessive, acquired in late childhood you find, and temporary cases you will find. Temporary, it's very common after infection. Okay, after infection. So it is very, very common thing. You will find it. Lactose intolerance can be temporary, and it is related to infection. That is important, and nothing more. But celiac disease, in celiac disease, important is this part. Okay, celiac disease has risk of developing lymphoma. That is high yield information. You need to memorize it. Because clinical cases I have about it. And why? You know, many people have celiac disease. Many people, because it is autoimmune condition, immune-mediated damage. You know, immune-mediated damage to small bowel villi. Pathogenesis here is important. You need to read. Pathogenesis is well explained in Golian. Okay, it's not complicated. Just memorize gliadin, the function, how it functions, what type of autoimmune reaction we have, and where the location. Okay, most common location is duodenum. For that reason, you have this deficiency. I remember it, if you remember actually, it was mentioned this hematopathology in anemias, right? In anemias, where we absorb iron, where we absorbed B12 and folic acid. Okay, and wherever you have damage, you will have appropriate anemia. Presentation, clinical presentation, why you have hepatitis, dermatitis herpetiformis. Herpetiformis means it looks like herpes. And celiac disease is related to immunoglobulin A deposition. Okay, immunoglobulin A deposition, that is important. Immunoglobulin A, you remember we had in vasculitis, we had in kidney, and we have this immunoglobulin A deposition here as well. But what I given in both, immunoglobulin A deficiency may be seen as well. Okay. Here is written that all symptoms resolved with gluten-free diet, but in long-term celiac disease, for example, question is what is the risk of, what is the increased risk in case of celiac disease? You should know that you might have cancer, okay? Small bowel carcinoma, you might have carcinoma, and T-cell lymphoma. T-cell lymphoma is more common. Okay, T-cell lymphoma is more common. Otherwise, carcinoma you should not find, guys. And more commonly, it will be carcinoid. But lymphoma is pure complication of celiac disease. Despite good dietary control, it does not matter if you control or not. Risk of the tumor is there. Guys, read please this tropical sprue and Whipple disease. Tropical sprue and Whipple disease are important. Definitely you have these questions, short questions and long-term questions. Morphologically, you need to make differential diagnosis and location as well. Jejunum, Ilen, I will send it to you, but please prepare from Golian. All right, Golian is very, very important. Many information you have here that are necessary. So that is our lecture, guys. Prepare everything until this part. Vascular disorders, there are small bowel diverticular, sigmoid diverticular, inflammatory bowel disease until here, okay, until K, to read from Golian. Then is tumor, small bowel malignancy. Then. So this page, 11 page, you need to read from Golian. 11 page. I will send this as well, and you can read the first aid as well. So your homework, guys, GI until inflammatory bowel disease from Golian. That is our portion. I have not.
Doctor, and inflammatory bowel disease is not included, or
yes, inflammatory.